Good evening, everyone. I thank Dr. Sudeep and Dr. Shonana for giving me this opportunity for this meeting. My topic for the rapid review will be triple negative breast cancer. So I have six abstracts. All of them are talking of immunotherapy in triple negative breast cancer and how we can increase the response of immunotherapy in triple negative breast cancer. So the first abstract is combination of famitinib with pembrolizumab plus nab-paclitaxel as first-line treatment for patients with immunomodulatory advanced triple negative breast cancer. This is the future C plus, a prospective single-arm phase 2 study. The background: pembrolizumab is a new anti-PD-1 antibody drug. It comes from China, and it has been combined with nab-paclitaxel, and it has shown promising anti-tumor activity. In the immunomodulatory subtype of metastatic TNBC in a previous trial, the response rate was 52.6%. We know if we combine an anti-angiogenic agent to an immune checkpoint inhibitor, the efficacy can increase further. And famitinib is also a new multi-VEGF TKI. It is blocking VEGF receptor 2, PDGFR, and c-KIT, again coming in from China. And this is being studied in combination with pembrolizumab and nab-paclitaxel in the immunomodulatory subtype of advanced triple-negative breast cancer. This was a phase 2 study of treatment naive IM subtype unresectable locally advanced or metastatic TNBCs, and the IM subtype was defined by CD8 positive cells by IHC. Eligible patients received the combination of pembrolizumab with nab-paclitaxel and also oral famitinib. The primary endpoint was overall response rate. If you see the results, 48 patients were treated. The overall response rate was seen in about 81.3%. The median time to response was 1.8 months. With a median follow of 9 months, the PFS and duration of response data were not mature. 9 months PFS rate was 60.2%. Biomarker analysis was done, and that showed that somatic mutations of GSK3A may have a potential to predict the immunotherapy response. Grade 3-4 adverse events were neutropenia, anemia, febrile neutropenia, thrombocytopenia, hypertension, etc. So the conclusion of the study was addition of famitinib to pembrolizumab and nab-paclitaxel showed a promising anti-tumor activity as first-line therapy with manageable toxicity profile for IM subtype advanced TNBC patients. My take on this: I think this is definitely a promising way of looking at responses enhancement in immunotherapy. You are looking at the TNBC subtype, which is the IM subtype, so it is definitely the one you will probably get the maximum response. And secondly, we have seen adding anti-VEGF TKIs to immunotherapy in various ways have shown good response. We have seen the pembrolizumab with lenvatinib data in various cancers from the LEAP studies, and we clearly see the response rate goes up. So here, when we combine all three, we're touching a response rate of about 80%. So probably this definitely has promise in the future. In the normal pembrolizumab and chemo combinations or atezo with chemo combinations, we get a response rate of about 60%. So probably there is a promise in this in future. The second abstract is a Begonia study. It is a phase 1b/2 study of durvalumab combinations in locally advanced metastatic triple-negative breast cancer. These are the initial results from the arm 1, which is durvalumab plus paclitaxel, and arm 6, which is durvalumab plus trastuzumab deruxtecan. This is a two-part multicentric, multi-arm open-label platform study. It is evaluating safety and efficacy of durvalumab with paclitaxel and durvalumab without paclitaxel in patients with TNBC. Now, in the arm 1, it is durvalumab paclitaxel. In arm 6, it is looking at durvalumab plus trastuzumab deruxtecan, which is a very interesting arm. So these are untreated patients of TNBC metastatic first-line patients. Patients also had HER2 low expression tumors are assigned to the durvalumab trastuzumab deruxtecan arm. They are not the HER2 3+ patients, they are the HER2 low patients. Now, patients who got durvalumab paclitaxel got this with weekly paclitaxel, and patients in arm 6 got durvalumab and trastuzumab deruxtecan every 3 weeks. The primary objectives were safety and tolerability. Secondary objectives include overall response rate, duration of response, and the PFS. In the arm 1, 23 patients received the treatment. 2 discontinued due to side effects. The major grade 3-4 events were experienced in about 10% patients. Confirmed overall response rate was seen in 57% patients, and 54% of these patients continue to respond at 12 months. The median PFS was 7.3 months in the durvalumab plus paclitaxel arm. Arm 6 is the very interesting arm where you're looking at the HER2-low patients, durvalumab plus trastuzumab deruxtecan. Only 11 patients have been treated till now. Median follow-up time is 2.3 months. If you look at grade 3-4 events, it is seen in about 36% and 1% respectively. The confirmed overall response as of now is all 4 patients out of 4 have responded. Now this is a very, very short-term study. These were only 4 had become evaluable. So really very, very initial data. So they concluded durvalumab paclitaxel demonstrated a tolerable safety profile and response rate as expected for a first-line TNBC IO taxane combination. We've already seen these from the other IO taxane combinations. Durvalumab trastuzumab deruxtecan showed promising early safety and efficacy in the first-line HER2-low expressing TNBC. A very interesting arm to follow up with. Let's see how this shows up in future. The third abstract is Ramadipsan. This is a HDAC inhibitor plus cisplatin and nivolumab triplet combination in metastatic patients of TNBC. It was seen that if you HDAC inhibition, that's the histone deacetylase inhibitors, they upregulate genes involved in antigen-presenting machinery and increase the expression of NK2 cells. So thus they are increasing the immune response. Now cisplatin and HDAC combination has some synergy, and this increases the cytotoxicity, apoptosis, and DNA damage. So this study was investigating a triplet combination where you're using Ramadipsan plus cisplatin and nivolumab in the metastatic TNBC patients. These are patients who had received multiple lines of chemotherapies, and they were the phase 1 study was a 3+3 dose escalation design, and then there was a phase 2 part of this. The primary endpoint was choosing the recommended phase 2 dose and then the objective response rates, and also to look at safety, PFS, and pharmacokinetics were the secondary endpoints. 51 patients were enrolled. 69% had patients had received prior lines of therapy. The recommended phase 2 dose of Ramadipsan was 12 mg meter square with cisplatin of 75 mg meter square day 1 and nivolumab 360 mg day 1 every 21 days. The main side effects seen were thrombocytopenia, neutropenia, anemia, nausea, and vomiting. There were 21% patients who had immune-related adverse events. Among the 34 evaluable phase 2 patients, the overall response rate was 44%, median PFS was 4.4 months, 1 year PFS was 23%, median OS was 10.3 months. So the conclusion, the triplet combination of Ramadipsan, cisplatin, and nivolumab was well tolerated, shows encouraging efficacy in pre-treated patients, and there are some correlative biomarker work going on. Again, I think this study is a very early study to really come into clinical practice. We really have to see bigger data to kind of think how this will work out in our patients of TNBC. Another study was looking at Endinostat, nivolumab, and ipilimumab in advanced HER2-negative breast cancers. Now, Endinostat is also a HDAC inhibitor. Again, we have seen that HDAC inhibitors in murine models of breast cancer, it increased the CD8 effector cells, and the ratio of the effector versus the regulatory T cells, the FOXP3 cells, gets improved. And due to this, the efficacy of the checkpoint inhibitors can improve. So this was a phase 2 study. It was looking for safety and efficacy in the HER2-negative population. Again, very small population of patients have been treated. Primary endpoint was safety. Secondary endpoint was looking at change in tumor CD8 FOXP3 ratio and objective response rates. 24 patients were treated. 12 patients had hormone receptor positive disease and 12 patients had triple negative breast cancer. The thing about this was multiple lines of therapy had been used for patients and about 6.5 lines of therapy were medianly used. Grade 3-4 adverse events were anemia, decreased ANC, and increased lipase. There were IRAEs also in about 29% of patients. The overall response rate was 30%. And the conclusion was the combination of Endinostat, nivolumab, and ipilimumab had expected side effects. And the overall response rate, 30%, suggested the combination should be evaluated further. Again, there are biomarker studies going on further. And a very interesting combination because everyone's interested in HDAC because it may improve the immune response, but we'll have to wait for further data to see how this pans out. Another study interesting for clinical use It is Nimbus, a phase 2 study where you just combine nivolumab plus ipilimumab in metastatic hypermutated HER2 negative breast cancer. We've seen that approximately 9% of metastatic breast cancers are hypermutated, and this is defined by a TMB greater than 10 mutations per MB. The aim of this study was to look at this population of hypermutated HER2 negative MBC patients and treat them with nivolumab ipilimumab. An open label study. Here the doses were Nivo 3, EP1. Nivo was given 2 weekly, EP every 6 weekly. This is almost like the lung cancer date where we talk of Nivo 3, EP1. Now, patients were HER2 negative, TMB greater than 10 was calculated using a gene panel which had more than 300 genes. Primary objective was overall response rate. Secondary objectives were looking at safety, tolerability, PFS, and OS. 30 patients were treated. Overall response rate was 16.7%. 4 of the 5 individuals have had durable response that lasted longer than a year. The median OS was about 19.3 months. Now, it was seen that patients who had higher than 14 tumor mutations, though they were a minority, they had a response rate of about 60%. Conclusion, study supports the use of dual checkpoint inhibitors in HER2 negative MBCs with high tumor mutation burden. But again, we don't have really great answers in this setting whether dual is better than single. But the TMB high population may be an interesting population where immunotherapy may work better. We'll have to see more data, but this is a place where everyone's interested in using immunotherapy. The last study is the Barbican. It is a randomized phase 2 study to determine the contribution of ipatasertib to neoadjuvant chemotherapy plus atezolizumab in women with triple negative breast cancer. Now, in TNBCs, we have seen PCR to neoadjuvant chemotherapy has a correlation with event-free survival and overall survival. There has been now clear data and approved data of combining neoadjuvant checkpoint inhibitors with neoadjuvant chemotherapy in TNBCs because the PCR rate goes up. Now, there is a preclinical study which show that AKT inhibition can enhance the checkpoint inhibitory effect. And we have data from ipatasertib, which is the AKT inhibitor, with combination of paclitaxel in metastatic breast cancer TNBCs. So Barbican was designed to evaluate the biological effect of adding ipatasertib to neoadjuvant chemotherapy plus atezolizumab. Now, this is a phase 2 study where patients with TNBC taken up as a neoadjuvant setting, receiving atezo plus ipatasertib, followed by atezo with weekly paclitaxel plus ipatasertib, followed by atezo plus AC dose dense, and then they undergo surgery. Tumor biopsies are taken up at regular intervals, and the primary clinical endpoint was PCR rate. PDL1 was assessed using the ST142 assay. 144 patients treated, 72 in ipatasertib, 72 in no ipatasertib. There was no difference in PCR rate between the two treatment groups. Now, what you see, even chemo atezo ipatasertib, 49.3% PCR. In chemo atezo alone, 48.5% PCR rates, which is exactly the same. The grade 3 and higher adverse events were seen in 73.6% of ipatasertib group, while it was 40% without the ipatasertib group. And there were more side effects were in the form of rash, neutropenia, diarrhea. So conclusion, addition of ipatasertib to neoadjuvant atezo plus chemo did not improve the PCR rates. Ipatasertib dose intensity was low due to increased toxicity also. So clearly, AKT inhibition at present is not going to be of value looking at this elegant study. So probably ipatasertib may not have a role to play in neoadjuvant setting to increase the response of immunotherapy. With this, I thank everyone. We clearly see there are many ways of trying to improve immunotherapy responses, and we'll have to see in future which may be the best option. As of now, chemo plus immunotherapy is the way forward. Thank you very much.